have had our standard anti-epileptic treatment for children with Dravet syndrome. Namely, our go-to treatment has been sodium valproate with stiripentol and then possibly clobazam added in as well. What has been exciting recently has been the investigation of newer treatments. Cannabidiol, this is cannabidiol with less than 0.2% THC, pharmaceutically prepared by GW Pharma, it's called Epidiolex, has been tried in randomised controlled trials and been shown to be effective over placebo. That means a non-effective treatment, and indeed has recently been approved by the European Medicines Agency, and now NICE have approved it for utilisation in children with Dravet syndrome. So this gives us another anti-epileptic drug that we know can be of benefit in some children. It's to be used in conjunction with clobazam, but that aside, we know it can be effective in children with Dravet where seizures can be quite difficult. Another new treatment that has been tried in randomised controlled trials is a drug called Fenfluramine. This is a drug that was tried for appetite suppression way back in the 1960s, was then trialled, you'd think surprisingly, but it was trialled for reflex epilepsies, and particularly photosensitive induced epilepsies in the 1980s, and taken back and utilised in a group of individuals with complex epilepsy in Belgium. On reanalysis of those who responded, it was determined that many of them had Dravet syndrome with a sodium channel mutation. It's gone on to be trialled in randomised controlled trial and been shown to be incredibly effective in individuals with Dravet syndrome. This has now been submitted for approval, and we have to wait and see when and if that will happen. But I think this is a very exciting new treatment for children with Dravet where seizures are rarely controlled, but in the studies with fenfluramine, many more of them had a significant reduction in seizures. I think many of our treatments to date have been targeted against the seizures. And yes, seizures are important in Dravet syndrome, but we know there are other factors that or problems that really do trouble families and the children themselves. Obviously, the fact that they show little in the way of neurodevelopmental progress, so their IQ appears to drop. That doesn't mean to say they lose skills, they just don't progress relative to their peers. And behaviour and communication, which becomes quite problematic to a varying degree, but can become quite problematic. And the problem we have is we are treating symptoms. If we're suppressing the seizures, they are one of the symptoms in Dravet syndrome. The learning and the behaviour and the communication are other manifestations and are symptoms, but we haven't got anything really to target that. Yes, in some of the behaviours, such as attention difficulty, we can treat them as we would any other individual with attention difficulty, but actually it's not targeted at the cause. So cannabidiol and perhaps to some degree fenfluramine is targeted at the seizures. Some of the, we're waiting to see whether fenfluramine is effective in any other types of epilepsy. There are some animal studies that suggest that it has a very specific mechanism that may be relevant to Dravet syndrome, and indeed some of the early data suggests there may be some improved attention in children who go on fenfluramine from the studies. So there may be some degree of symptom targeted treatment there, but we don't know yet, and it wasn't designed that. We have done our trials to look at seizure control, and we're waiting to see whether it has any other benefit. When it comes down to it, the problem is the genetic problem. It's the sodium channel mutation, perhaps not just that we find, but maybe other hidden genetic problems that is the real problem. And it's that probably needs to be targeted if we're going to have an overall effect on the long-term outcome of these children. We have some genetic studies planned. In the first instance, looking at antisense, which means we're bypassing a problem to enhance the production of proteins in the brain. But then there are also animal studies looking at other more targeted gene therapies. These are very early days, but it's something that we have to look towards if we're going to have an effect on the overall condition and not just treat the symptoms. we continually look at our anti-epileptic treatments, and some of the drugs are more promising than others, but again, we're only treating seizures. Yes, we are excited about fenfluramine, but we have to wait for approval. There is also some recent data looking at genetic therapy. It's not gene therapy, it's genetic therapy, in that we're looking at hidden abnormalities in the sodium channel gene and whether we can bypass those abnormalities to enhance, as I said, the normal protein that is required in order for the brain to function. And that is something that is on the horizon. There are trials planned next year. Those are the main new therapies that are out there. Cannabidiol, as has been approved now by the EMA, the MHRA, and also the HTA, the NICE HTA, to allow it to be prescribed on the NHS for children with Dravet and Lennox-Gastaut syndromes, is a specific product. Cannabidiol as produced by GW Pharma with less than 0.2% THC. Tetrahydrocannabinol, which is the THC, we don't know whether that is required. We've got no evidence that it is required over and above cannabidiol, and there are some concerns about significant amounts of this causing further learning and behaviour problems, considering it is the psychoactive component of cannabis. Yes, we are looking actively at developing trials for this, and maybe we'll have the answer to that in the future. We also have to bear in mind, however, that it's not the same as the oils that can be purchased over the internet. The oils produced, they're cannabidiol-enriched oils. They are produced through doesn't have the same quality assurance rigor that a pharmaceutical product does. We know there's evidence there's variability in what's in from those products from batch to batch. We have to remember that cannabidiol can have interactions with other medications, and therefore to give these oils, there's no rigor to that. We don't know what's being given consistently, and even indeed what sort of dose. I mean, in many of them, it's really minuscule doses. So these aren't something that we can approve or prescribe because they are not within our remit to do that. So we strongly recommend that if a family is considering that they want to look at cannabidiol, they should discuss it with their physician, consider whether they then are suitable for the Epidiolex as per the current NICE and ultimately NHS guidance. When trying to decide whether patients should be hopeful, it depends what we're hopeful for. For seizure control, I think we've got fenfluramine is very exciting. In some, cannabidiol has been effective. So yes, these are therapies we did not have before, and showing more effect than our old traditional anti-epileptic drugs. And yes, with the experiments that we've seen, as far as genetic and possibly even gene therapies, but it's not round the corner. We have to bear in mind that these take a long time to develop, so it is sometime in the next 5 years. But that aside, it is very exciting, and we know a lot more now than we did 5 years ago. When we're deciding on these therapies, there's always an issue about when we can intervene and at what point we can intervene. When the diagnosis is made, how do you make the diagnosis and at what point do you start interventions? So I think if we not only find something that can affect the underlying genetic problem, but also determine an optimal timing for that intervention, then significantly improving Dravet syndrome outlook is a real possibility. Cure, I'm not going to say it's impossible. I don't think it's around the corner, but certainly having more of an effective treatment for the genetic abnormality itself, it gets us closest to that.